just about anything in medicine, and particularly surgery, you have to consider the risks as well as the benefits. So from the risk side of things, I mentioned early on that traditional hearing aids are really attractive because there's really no surgical risk. But let's start with the bone-anchored hearing aid. So the classic Baha system, which includes an abutment or a post that's implanted behind the ear. One of the traditional concerns about the Baha is skin reaction around the post. And as you can imagine, it takes a bit of healing as well as medical management to make sure that the scalp right around that post, where it sticks out through the skin, doesn't develop things like infections or irritation. Thankfully, your body actually does that type of interface fairly commonly. And the bone-anchored hearing aid technologies, as an example, came directly from the oral dental implant literature. So they put the exact same implants into the area of the gum or the jaw, and that's where the tooth attaches to. That interface between your tooth and your gum line is another one of these tissue, hard, artificial surface interfaces that your body knows how to navigate and heal. Another simple example is where your nail meets your cuticle on your fingers. That interface is, again, a similar type of junction where your body has figured out how to make that heal. In the old days, when we first started doing bone-anchored hearing aids, we actually sent patients home with a small toothbrush and very explicit instructions on how to clean around the post in a fastidious fashion daily. And we thought that keeping it clean, keeping the bacterial count around the post was the most prudent thing to do. However, over the next decades, what's actually shown to be the most beneficial is to do the very minimalist and just do the routine hygiene that you normally do when you bathe and shampoo. It turns out when we were obsessively cleaning around these bone-anchored hearing aid posts, we were removing some of the natural flora or bacteria that were on the scalp. And there's a very typical skin biofilm that should form. And when you constantly remove that natural biofilm, you remove a natural protective effect that it has. And then atypical bacteria and organisms would grow in. And that's actually when we get infections. So despite all of our learnings and the improvements over time, there's still a couple of problems with bone-anchored hearing aids. Some people just have sensitive skin, and the area around that titanium post or stainless steel post comes chronically irritated, and we have to treat them with anti-inflammatory ointments like steroid creams. Occasionally we'll use antibiotic preparations if the skin area gets irritated. There's still about a low single digit, somewhere in the 2 to 3% range for us, where patients need to eventually have the post removed because of just chronic irritation that's more of a nuisance than any type of benefit. As patients have lived with bone-anchored hearing aids even longer, one of the problems we've seen is that their scalp naturally grows and gets thicker over time. And concomitantly, the bone of the skull also gets thicker and taller over time. What this necessitates is that you have to create longer posts so that the post doesn't get recessed and lose its projection over the skin surface. And that can be a real nuisance over time. Some of our patients will go scalp reduction or cleaning up of the skin right around the post so that it reestablishes that height of the post so it can be attached to the hearing aid. This is one of those reasons why some of the bone-anchored hearing aid companies have moved towards internal devices where that wouldn't be an issue. But again, going back to considering all the risks and benefits, placing a bone-anchored hearing aid for us these days typically is about a 10 to 12 minute procedure. Placing something internally like a bone bridge hearing aid, it's more on the lines of 2 to 3 hours of surgery. So all those things have to go into consideration. Next, we'll also think about some of the potential complications with a cochlear implant. The ones that are classically described involve the surgical insertion. When putting in a cochlear implant, a mastoidectomy is first performed, And this is that hard bone that you feel right behind your ear. We need to place the device through the mastoid bone. So using a surgical drill, a small window is created in that bone. Next, as you go into the inner ear and are trying to approach the cochlea so that you can insert the array, you have to identify a structure called the facial nerve. So the facial nerve is the one that moves all of the facial musculature on that side of your face. And for whatever reason, we're designed so that that facial nerve runs directly through the ear and through the middle ear and mastoid cavity. What the surgeon has to be very careful of is not damaging that nerve. Otherwise, it looks like somebody's had a stroke or a paralysis of that side of the face. This used to be a really significant concern for people and surgeons, but several things have really mitigated those risks. And currently we're at the point where we consider that less than a 1% risk, even in our children with CHARD syndrome. So first, imaging, whether it's CT scan or MRI scans, demonstrate the course of the facial nerve very clearly. And so it gives the surgeon the ability to identify that nerve and anatomically, surgically make plans as to how to keep that safe. Universally, people doing cochlear implant surgery will also place a facial nerve monitor on the patient during the time of surgery. This alerts the surgeon if they're irritating the nerve at all, and so it's another safety mechanism that's in place. And then finally, with cochlear implants and this type of surgery being performed on a routine basis, the surgical experience with it is definitely one of the key variables that makes it a much safer procedure. Finally, the insertion of the array is become very standard, and even in people who have abnormal anatomy, there's a variety of different cochlear implant shapes, lengths, and structures that have made it remarkably easier to insert them. The other issue in some of our patients is the use of the external magnet as well as the internal magnet puts a little stress on the scalp where those two interface. It's almost as if the scalp was being pinched between the two magnets, which it is. If that's not done properly and the magnet strengths are not adjusted just right, there's the potential to cause a pressure ulcer. And the concern with that is if the skin breaks down over an implant, the implant can potentially get seeded with bacteria, the device get chronically infected and need to be explanted. Thankfully, that's again in the 1% range, and I think current surgical techniques have made that much lower risk. One final thing to note is that the inside of your cochlea has a certain fluid that is directly in communication with the spinal fluid that surrounds your brain and spinal cord. And early on, before this was really well recognized, there were some cases where infection and bacteria would track in through the implant to that inner fluid compartment of the cochlea, and then it had a natural spreading pathway to the spinal fluid of your brain and spinal cord. If that gets infected, then that's what we call a meningitis, which has obvious, very severe and life-threatening effects. I think the best safeguards for those have actually been the universal vaccination programs against specific types of meningitis bacteria. This would include things like Prevnar, Pneumovax, that protect against pneumococcal meningitis, and also Haemophilus influenza vaccines that protect against that H flu meningitis. Since that's occurred, we really have seen exceedingly rare cases of meningitis associated with cochlear implant. And that would really be the rare exception to the rule these days. I think those are the major things that we talk about potential risks for our patients undergoing both bone-anchored hearing aids as well as cochlear implantation.